Good morning. Absolute pleasure to be here with you and a lot of like-minded folks who are very interested and passionate about the workforce for persons with serious illness and their caregivers. I'm going to focus on the specialty, two specialties in particular, one, geriatric medicine and gerontology and the related specialties, as well as specialty palliative care. And I'm going to let my other colleagues talk about a broader workforce, much broader than just the specialists. And we're going to walk through a little bit of the data of what we know and what we project to give you a sense of kind of what's coming along and how to maybe potentially best prepare, with 5 recommendations at the end, particularly related to policy. So I want to start by showing you exactly what Bryn had brought up, which is the NCP Quality Framework for Palliative Care, which has been around since the early 2000s and late 1990s and recently updated. And what's consistent in that is really sort of an 8-domain framework for measurement of quality in specialty palliative care. And what you can see is that not only is there a focus on the things that seem obvious and make sense, like physical aspects and structure, but also aspects of things that lead to patient suffering and that of their caregivers, which is cultural and social aspects of care. I took care of a patient yesterday in outpatient palliative care clinic who, with very low health literacy, was having trouble with the compliance for his opioids for very significant pain related to his prostate cancer. And there were lots of other psychosocial issues involved that we actually had to talk through and is very important. I also took care of a woman yesterday in clinic 37 with a mediastinal mass that was still yet to be diagnosed, who was dealing with her house recently being condemned. And we had to talk through lots of areas of distress, not just related to the physical aspects of how she was feeling, but how she was overall coping with a very significant illness with a lot of uncertainty still ahead of her. What we also recognize is that we are moving now towards understanding specialty palliative care as being really related to the integration being related to complexity as opposed to prognosis. Historically, we had thought of, because palliative care's birth was out of the hospice movement, that we thought a lot about time and prognosis and stage of disease. As a medical oncologist, we make a lot of decisions about stage of disease, and a lot of our conversations actually sort of revolve around understanding that a person is stage 3A versus 3B versus 4. But what we're understanding in specialty palliative care, that this is actually about need, unmet need and complexity that can span much more than anything that one would find on a CT scan. In fact, if you looked at my 37-year-old patient's CT scan from yesterday, it was a mass that probably would be underwhelming to many oncologists, but yet the conversation that we had was very serious and significant because this was a life-changing event for this woman that was sitting in front of me. So as we think about complexity, we recently published different sort of domains of complexity, and others have thought about this as well, where we really thought about actually maybe this is more of a funnel, where really we're thinking about palliative care specialist integration at the top of the funnel being foundational, using palliative care specialists to be guides and stewards and helpers and educators across the health system to help the really great care provided by primary care clinicians and oncologists and pulmonologists and cardiologists to provide foundational palliative care while also receiving help and curbside support from palliative care specialist teams. That as the complexity starts to increase over time or stage or other things that happen in a person's life with serious illness, that in fact you start to see where greater integration of specialty services starts to make sense. This is now starting to transition away from the concept of time or prognosis to really understanding that we have to know what a patient and their caregivers' needs are before we can understand sort of the right level of service. We also then, in the specialty of geriatrics, understand that there's also domains of quality as well. And if you take the geriatric assessment, for example, you can see that there's very similar domains as well. So social support, nutrition, and cognition, and other ways to understand preemptively what issues may come up over time for a person facing a geriatric syndrome and their loved ones. You can start to see that there's actually quite a bit of overlap and support here between the two specialties together. And actually, this slide from Sean Morrison and Elizabeth Lindenberger, which I think is really fantastic, starts to show the overlap of geriatric medicine and specialty palliative care, which Capsy and Diane and others have moved forward, which is really understanding this appreciation that there are things that sit on one side or the other side, but there's quite a few things that sit in the middle. And particularly pay attention to the needs of patients who can benefit from specialty palliative care who are not of Medicare age, which is where a lot of our data is. So these are patients who really start from the moment of conception for perinatal counseling and complex genetic syndromes and other things through birth and through moving forward to advanced age and potentially death. Think about those cystic fibrosis and traumatic brain injury, advanced liver disease. In my own practice, I think one of the youngest women I had sent to hospice was a 38-year-old woman who was dying of COPD. And in North Carolina, we've had a troubled history with nicotine and tobacco. And so listening to her story, she first started smoking when she was 7 or 8 years old. And so she had actually lived through 60 pack years at the age of 38, which is unimaginable to think about. And so now we were supporting her and where she was in her life trajectory, which was young children and a job and other things. So actually the conversation was a very different transition to hospice conversation. So this is also a population for us to think about and remember. There's also the idea that specialist palliative care clinicians, although being change agents in health systems, can't do this alone, and we have to think about actually accordioning out the workforce. And Dr. Dingfield will talk about sort of how this is happening with sort of competency-based training. But you can imagine that actually when we think about palliative care delivery, there's the entire workforce. And first of all, we should just say right now, officially deputized, is every person who touches a patient with serious illness is part of the palliative care team, first and foremost. And what we have to do is engage them with the skills and expertise and interests that they have and use that to help broaden the team so we can take care of patients in lots of different ways, regardless of where geographically they're receiving care. So I think a lot about the nursing aide, for example, who may see a patient and their caregiver and spend more time with them than a physician, for example. We think a lot about leaning heavily on our bedside nurses, particularly in the ICU, who intimately understand the conversations that patients and caregivers are having. That goes way beyond the time that we as clinicians may come rounding once or twice per day. So, several of us have thought about this idea of as we accordion out, that we should really think about the other folks that are involved. And so we, came up with the concept of the champion of palliative care. This is the person who may not have the time and space to take additional training that would be fellowship training, let's say, but this is the hospitalist who's on 7 West, who says, I really want to champion advanced care planning on this service for the patients that we admit. And we say, well, great. What we don't want to do is say, well, you're not a specialist palliative care person. You didn't do fellowship training, so let us handle this work. What we want to say is let's embrace that person who has that interest and potentially wants to gain some further expertise and bring them into the fold. Let's find the nurse who's in the ICU who says, well, we've been thinking about some QI projects to increase family meetings happening early on and bring them into part of the team, make them a champion, and so on. And lastly, making sure that we bring them into the network. And when talking about access, we know that there are several palliative care teams in the country who are not able to fully staff kind of the interdisciplinary model put forward by the NCP. And that's just reflecting the realities of what's there, part of it being payment, but part of it also being access and distribution, as was brought up by Dr. Washko. So in that model, how can we create a network, like in a hub and spoke type of way, where you do have interdisciplinary teams being able to connect with other teams in smaller hospitals across the country to be able to compare and contrast? My brother is an orthopedic hand surgeon, and when he asked me how we prepare for our boards, I said, well, we sit and we read about a bunch of things and then we take a test. He said, in surgery, what we do is we put forward our first 100 cases and we sit in a room and examiners ask us, how did we do X, Y, and Z? And I reflected for a moment with him. I said, I'm not sure there's been a lot of time that I've received direct feedback on my clinical care or maybe our team's approach. And wouldn't it be interesting if we compared how we do it to other hospitals in our area to truly create a community of learners? Here's kind of where we are in aggregate, both taking into place geriatrics projections for the American Geriatric Society, as well as palliative care projections from several different data sources. So the blue here is the number of clinicians that have been recognized to be in the specialty space specific to physicians. And I'm going to first say right now that there has not been as much robust data collection in the non-physician space, which I apologize for. So we're going to focus on physicians, recognizing that I think the gaps we're seeing here are probably going to be larger in the non-physician space. So in the blue, you see the physician projections, about 7,000 to 8,000 on both sides, geriatrics and palliative care. In yellow, what you see are the patients who are of advanced age in the geriatric projections and the patients with chronic or serious illnesses from the Commonwealth on the yellow. And then about the number of patients who would be eligible for services based on different definitions. And so either way you look at it, your denominator's in the millions, okay, and your numerator's in the less than 10,000. So no matter how you do the math, there is an imbalance. And frankly, the workforce issue is also sort of an intensity of time and space. If you look at my palliative care practice yesterday, I spent a minimum of 60 minutes with one patient because he came in with rapidly progressive dementia from multiple insults to his brain from metastatic lung cancer, who walked in actively dying to my clinic. And we got him into inpatient hospice, but that was time intensive. We were very hands-on with his family member. His older son who came with him was in tears because he said, I just can't do this on my own. And we looked at him in the eye and said, your father's not going home and you're going to get this type of support that I apologize we did not get to you so far. And so we spent an hour getting him to the right place at the right time, and that was inpatient hospice. We also took care of other folks where we recognized that there is a time intensity and a high-touch component to this that cannot be curtailed, and we can't cut corners. So the challenge is both the complexity and the challenge is the complexity, right? And so what we have to provide is complexity-driven care, recognizing that some of these things don't have shortcuts to them. So this is some work that we published recently in Health Affairs. And what we did was we tried to find the best available data possible to understand what's going to happen to the workforce over the next 40 years. We did a survey of the palliative care specialty workforce and received about 3,000 responses. That was thanks to the help from the members of and the National Coalition for Hospice and Palliative Care. They sent this out to multiple groups within their organization. And with those survey responses, we asked folks, what do they plan on doing over the next 10, 15, 20 years? And we asked them ultimately, when do they plan on retiring? And if the time period they gave was less than their age of 70 minus their current age. So we would call that early retirement. And we actually gave them a grace period of saying, well, not retirement at 60, but at 65, but retirement at 70. So if you retire early, we had a sense, and then we asked people why. Then we did a Markov model simulation of 10,000 simulations to understand, using hazard ratios from burnout and other things that predict people leaving the field early, to understand that if we multiply that 10,000 times, what's going to happen to the field. So what you'll see is here in 2019, we start at about just under 8,000. And again, this is just for palliative care specialty physicians. When you start just under 8,000, what you actually see is really 4 different projections. We did the base case, which is the bottom line, the base case plus burnout reduction, which is taking the prevalence of burnout in the field and taking the best available evidence to reduce burnout, which is about 15%, and projecting that through. The top 2 lines is dramatic fellowship growth. For the final visual, we had to take out the word dramatic, but the reality is it is quite dramatic. It is the growth in 25 additional fellowship positions per year for the next 10 years. So that's an additional 250 positions that would cap out at 575, which CAPC's put forward. It might be tenable to get to between 500 and 600, but it would take a lot of work to get there. So we were really trying to say, in the best case scenario, what's possible. And what you see is no matter what happens, even in dramatic fellowship growth, what we see is a valley, what we call the workforce valley, that persists for at least the next 15 years, which is that the number of palliative care physicians we project will actually go down before it comes back up. And the reason for that is that the average age is right around 56. So what we're seeing is usual retirement coming into play. And what I'll show you in the next figure is actually then the growth of patients eligible for palliative care. So we map that against the growth in Medicare patients using Amy Kelly's definition of about 12% of all Medicare patients being the denominator, and came up with a ratio. Right now we have one palliative care physician for about 800 Medicare patients who are eligible for palliative care using Amy's definition. That gets to as bad as 1 to about 1,400. What's interesting to remember here is that this is only Medicare, and there's certain data sets that show that maybe up to half of all palliative care consults are actually done in younger populations, as I talked about earlier. So think about these numbers and double it. Well, what does 1 to 1,400 look like? Well, I told you an example of what my outpatient palliative care practice looked like yesterday. 1 to 1,400 means every palliative care physician, if they worked 48 weeks out of the year and worked all 5 days of the week, let's say for clinic, and saw every serious illness patient 4 times per year, let's say quarterly, they would have to do 23 visits per day. You double that to get to patients under the age of 65. So that's 46 patients per day. That's frankly impossible to do and maintain quality and value. Impossible to do. So let me get to what we think is important, and several of the co-authors of our health affairs papers here in the room A couple things. One is this workforce valley we think is real and is going to persist for a period of time without sort of dramatic changes in policy. Two, that ratio will worsen and will become to an untenable place. And then our 5 policy recommendations are: 1, we congratulate the passage of the Pachita Act through the House. Now we have to get it over the line through the Senate. 2, we need to expand advanced training opportunities that do not involve fellowship training. We need to bring in all the members of the interdisciplinary team and provide both an introduction and a welcome and a warm embrace to say, you are part of this workforce and we will make sure you have the skills to do this. 3, we actually need more research in the palliative care specialty workforce. I've just demonstrated to you that we don't have a lot of data outside the physician workforce. We need to pay for team-based care, which means that we have to embrace and recognize the hard work that's done by non-billable providers in providing palliative care. And last, even though we did not show that burnout is a huge mediator currently, you have to recognize what we're doing is as the workforce constraints get harder, that we likely could project that burnout might go higher and will actually create a new crisis that we have not seen yet. So with that, thank you.